Hi, everyone.
Okay, sorry about that. So we're getting ready to broadcast in about 1 minute. So I just friendly reminder to please turn off your cameras and microphones. And then we'll be live very shortly.
Okay, well, it looks like it's about time for us to get started. And thank you all for being here. I just want to give a chance for our committee chair, Guy Palmer, to maybe make a few opening comments. Is that okay, Guy?
Yes, it is. Yeah, so I don't think you can see me right now, but with the screen up, which is fine. I just want to wish everyone a good morning, good afternoon, or good evening. I know we always have multiple time zones going on. So thank you for attending, and I'm very much looking forward to this second set of committee meetings. I do want to remind everyone that this is a meeting held by the National Academy, and the comments that we make, there's many comments can be made. These do not reflect opinions or decisions. Let's start my video. All right, hold on. There we go. I'd like to remind everyone that this committee of the National Academies of Sciences, Engineering, and Medicine includes and is focused on commenting on the progress against the national strategy of combating antimicrobial resistance, and that the full task is described on the study website. As I mentioned, this is an open on the record session. And there may be individuals and members of the press that may be attending as observers. However, this is not a news conference, and we will not be entertaining questions from the floor. Reporters who would like to speak with committee members, the best way to do that is to touch base with the study director, Jillian Buckley, and her contact information is also on the study website. So I want to remind everyone this is, at this point, an information gathering session. We're in the process of assembling materials that the committee will examine and discuss in the course of making its findings, conclusions, and recommendations. So there may be provocative questions. These do not reflect conclusions by the committee or by any individual members. They're just part of the process of beginning to probe into where the gaps are that this committee can best address. So with that as a preamble, again, I want to welcome everyone and look forward to our presentations today.
Super, thank you so much, Guy. And I think I see our colleagues from GAO are already on. Dr.
Yes.
Parsons?
Yes, good morning, Jillian. How are you? Yes.
Good morning. Hi, thank you for being here.
Great to be here. Thank you. So I'm going to share my screen. Is that okay?
Yes.
Please do. Yeah.
Okay,
Well, the
great.
floor as it is yours.
Great, thank you. Okay, thanks, Mr. Chairman. So good morning or afternoon or evening, wherever you may be, everyone. Thank you, first of all, to the committee, to Mr. Chairman for introducing us and for having us at this meeting. This is a very important topic and we're pleased to be here today. I'm joined by my colleague, Mary Dennigan-McCauley, who will be taking half of the charts. I'll be presenting the first half, but we're going to try and keep it to our time. So we leave time for Q&A as was mentioned in the guidance. My name is Tim Persons. I'm the Chief Scientist of the Government Accountability Office, the GAO. We are the congressional watchdog for the US Congress, one of the relatively few congressional agencies. But our primary function is oversight, but we also do insight and foresight work. And that's an important statement because when we looked at this particular problem of antibiotic resistance, doing a study for the Congress, we wanted to make sure we were looking at this in a cross-sectoral, cross-cutting way, because even though our jurisdiction or remit is the US federal government, we know the problem is indeed bigger than that. So Mary will introduce herself when I do the handoff in just a few moments, but I'm just going to kick us off and go to the next slide. Okay, so we begin with the 2015 National Action Plan on this with 5-year goals. I think what's important is that even though these are sort of numerically compartmentalized, as it were, when we like to list things out, if there's one takeaway that I wanted to convey on this is just from my view, this is a complex adaptive systems problem, meaning it's not going to be enough to sort of check the box and achieve success on any one of these by themselves. They're all interrelated in a certain way as you go through the narrative, and that was important because the design of our particular study that culminated in a report that was issued earlier this year in March was based upon taking this sort of larger aperture view, as I call it. So first in the plan is to slow the emergence of resistant bacteria, preventing the spread of resistant infections. So that's basic prevention approach. Secondly, though, is to look at and strengthen the One Health surveillance efforts to combat resistance. Now, One Health is important because it means human and animal and anything vegetable or what have you in terms of flora and fauna. But our study, I should caveat and say, we did only look at human health, even though we do acknowledge the need for One Health surveillance. So I want to just caveat that we had to focus on what CDC could do and FDA in the human sense, but I think the One Health is an appropriate type of approach that folks are taking. Then the third area is to advance the development and use of the diagnostic tests. There's a lot of conversation about that. We at GAO have been doing work on diagnostic tests for some time. Mary is the director that oversees the Food and Drug Administration in terms of development of diagnostic tests and doing emergency use authorization. And we're in the throes of that right now, as you all know, in the COVID pandemic. But for the resistant bacteria, it's sort of the same thing. There are similarities in terms of what we're seeing in the pandemic, as well as what we found in our report, and we'll speak to that. Then the fourth is accelerating basic R&D. That's a key issue because there are market failures and there is a role for the federal government or the public sector to deal with that. And I know we're all feeling, again, the pain of that particular issue. Again, there's more to be said. And then lastly, this is not just a US only game. This is a thing where we have to coordinate across all, it's an international problem. And so that sort of runs throughout. But again, all 5 of these interrelate. And so our study objectives, the questions that we asked, map essentially directly into the National Action Plan. And so you'll see it's a little bit out of order, where number 1 starts with the NAP goal 2 and so on. But again, focusing on the fact that GAO's remit or jurisdiction is on the US federal government. We have no jurisdiction over the various states. That's important because so much of the public health surveillance game happens at the state and local level and in various facilities and hospitals and so on. That's important to our study. But nonetheless, looking at CDC on how to conduct surveillance as sort of the pinnacle of collection of that statewide data, to be able to do it is what we were looking at. We also looked at, again, diagnostic test development, as I mentioned before. We also looked at federal efforts to address the challenges for new treatments and things. Then the last 2 goals, or I'm sorry, 2 objectives were promotion of appropriate use of antibiotics, identification of challenges, and then again, international collaboration was threaded in throughout, again, a systems view. So here's the bottom line up front in terms of our overall key findings. Since the NAP was released in 2015, agencies have made progress on various facets of antibiotic resistance in the US and abroad. However, here's the thing, is that the precise magnitude of the problem of antibiotic resistance and its trends over time remain unknown. So for example, I just inserted a slide real quick that was a graphic on the spread, cumulative spread of CRE from 2001 to 2007. And so you see this is, in my words, what I call the more silent pandemic that's been going on. As you all may know, there's millions infected with antibiotic resistant bacteria every year. And right now, in terms of the clean data, what CDC has reported are about 36,000 deaths, but it's believed that that number is very low. It may be as high as 4 times that, or something on the order of 120,000. So the key issue is, because our surveillance is not working or limited, we just don't know the precise nature of the problem. We know we have a problem. We know that it's big. We just don't know how big, and we don't know how to tackle it in the way that it's been laid out, the issues in the NAP. Secondly, the key finding was that the development and use of diagnostic tests face obstacles. Of course, one of them is market failure. Another one is having a device having to go through regulatory process, which is the necessary friction for a device. You want it to make sure it has specific, good enough specificity and sensitivity in its testing, so that when you deploy it, it's better than a coin flip. But you also have another layer of regulation in terms of just the use, the CLIA waivers and things that are designed for these tests when they're in clinical structures. So there's a lot behind that. And by the way, you don't make a lot of money in general on diagnostic tests until there's a major problem, as we're all seeing again, and COVID's a good example. The third point was that the industrial antibiotic pipeline is struggling with the economic challenges. Again, another area of market failure. We did speak with the drug companies on that, and Mary can speak more to that in just a moment. And then lastly, adoption of practices. The idea of stewardship is limited by a variety of challenges that Mary will describe. So here's the major findings in the first objective on surveillance is that the CDC's made efforts. Again, progress has been made, more needs to be done, and the more needs to be done is that there are data reporting issues. There are various modules that are reported with a high percentage, somewhere around 86% of the reporting system CDC uses, but others in terms of other antibiotic resistance is as low as 10% as of the time of issuance of this report. And so there's really an issue with just getting the data in there. And if there's one thing that I wish we could accomplish together is definitely getting a robust surveillance system. I know it's easier said than done, but that is critical, because unless or until we do that, we won't be able to understand the size and nature of the problem and how to tackle it. So I mentioned gonorrhea. That's an interesting, just the way we all of a sudden picked on one particular issue or one condition, gonorrhea. That was simply because it's the the best data available. It was the one case study we could have. But even of the gonorrhea data that we collect, only 1% of it is really used in this system. So you really don't have a representative sample of the US population. So even where the data are quote unquote good, that's relative to everything else, which is more often than not non-existent or very sparse. And so even with the best surveillance or most mature, we're still not where we need to be. Second, CDC faces challenges reporting and timely information on that. The timeliness is important. You need to have data standards. You need to be able to have the various systems report in a canonical way. And then third, it's detecting the resistance threats abroad. CDC is very good at being internationally connected, and but we need to collectively work on this because the US challenges are the same challenges around the world. Next, in terms of diagnostic tests, we recognize that agencies have helped advance. There's various components of doing this. And HHS and DoD have funded studies to do this, but they haven't defined or coordinated the leadership roles and responsibilities, clinical outcomes to get such tests developed. So there's some need for coordination among two of the major players in the US. But then secondly, our regulator, the FDA, has taken steps to advance it, but hasn't regularly monitored this. And there's a lot of research that needs to happen in what are called breakpoints, which is distinguishing when the amount of some given antibiotic is making or rendering a culture of some bacteria susceptible versus not. And so this is a lot of the basic science. It's very critical to understand how much one's to be able to do and to use. And so with that, I'm going to I'm going to pass the baton to Mary. And let me see if I can select her real quick. And Mary, I'll find you in just a moment. If you want to go ahead and get started, it's going to be over to you.
Great. Can you hear me?
I can hear you, Mary. Yep. I'm passing.
Great. Okay. My video is not showing. I have it on. I don't know if you all can see me or not, but I'm going to
We can see you.
Go ahead and get started. Okay, great. So thanks so much. My name is Mary Denigan-McCauley. I'm a director of public health at the GAO, and Tim and I co-authored this with our colleagues, some of who are on the line with us today. And so when we get over to looking at the pipeline, as Tim had mentioned, it's not a surprise that the experts are concerned about the pipeline and whether or not we have sufficient antibiotics and incentives to get them to the market and keep them on the market. One of the concerns, obviously, it's not a surprise again, is that it can take years to develop these, and the investment that is put in, they just can't get the return. And they haven't, the agencies have taken a variety of different steps to be able to help get some of these antibiotics into the pipeline. Money has been spent, there's been grants, there have been public-private partnerships. They've done a variety of different things. And one of the concerns, though, is that during 2019, when we did our study, two of the major companies actually went bankrupt, got out of the market, despite the fact, oh, can you go back there, Tim? Did I do that?
Yeah, there we go.
I must be in control.
Right, yep.
There we go. Sorry about that.
No, keep going.
So we have these, what we call pre-market or push incentives. So for example, being able to provide the grants. And we have these post-market incentives that are out there, for example, providing market exclusivity. But even with these pre and post-market incentives, we still see companies not able to stay in business. And we had made a recommendation. Our report went and we spoke with a variety of different experts and reviewed documents, and we had made a recommendation that FDA or HHS really needs to take a look at the incentives that they have to help develop the pipeline. And they agreed that the pipeline was important. However, they were not in agreement that necessarily pool incentives, should be a part of that. They didn't know if that post-market incentive would be important. And HHS had, at the time of our review, they had a study underway to look at the current set of incentives to see if they would be sufficient. And we received an update in October, just a couple of months ago, that they are finalizing that report. And it's not clear to us if they're considering the post-market incentives or just the pre-market incentives in that. So we'll be watching that closely. All right. So Tim, I don't know if you have control. I'm unable to, could you go to the next slide?
Next. There you go.
I think you must have it. Thank you so much. So when we look at antibiotic stewardship, really, I mean, for GAO purposes, we have to divide this out into a separate area. But I mean, stewardship cuts across everything that we're talking about. Good diagnostics that can get us answers about resistance, quickly and not having to wait 72+ hours is all a part of antibiotic stewardship. But in our case, what we did was we looked at the federal efforts that they have underway to promote it. And of course, there's a variety of steps that have been taken. For example, there's been online training, CDC has increased its surveillance, research has been funded, but again, the GAO as well, their steps have been taken, some challenges. And some of the key challenges that we face is that some of the agencies, for example, from the federal perspective, such as DOD or VA or even CMS, with the Medicare and Medicaid, they have really good levers that they can pull to say that, look, if you want to get federal dollars, then this is to receive the funding. But that's limited. While Medicare certainly makes up a large portion of our a significant part of the nation's healthcare expenditure, it's up into the billions. It's certainly not everything. And only certain hospitals or healthcare facilities, for example, hospitals and nursing homes are examples of where they're able to pull that lever to get that compliance. But it certainly is not in every setting, and particularly in outpatient settings. One of the other areas of concern is that CDC does not have complete data, the surveillance data. So there's no central database. While VA and DOD have an ability to ask for their information to be pulled into a central database, that's not the case for the rest of the information coming in. Training also may have limited success. If you look at training, there's still a variety of things that can be of concern. I mean, you have a very short period of time when a doctor's in that office with that patient. And if that patient is demanding that something be done, for example, for an ear infection, it's very difficult for that doctor to be able to take more time to explain of why they may not be the best case. So in our report, we outline a variety of reasons of why this may be challenging. Good. Tim, there we go. Okay, it did work. I guess I am in control. Sorry about that. So the task force is charged with an annual report that they have to put out on their progress that's being made. And one of the areas that we noticed in the CARB task force in these annual reports, they weren't actually reporting out on some of the barriers, including the barriers that they were encountering with trying to get good stewardship. And it wasn't limited to just the stewardship. There were other areas as well. For example, it did not talk about the challenges, as Tim had talked about, with the gonorrhea and the surveillance related there and any steps that they were taking to overcome that. And the challenges with increasing antibiotic use data collection was another area. And there are efforts underway to try and overcome some of those barriers. And so we recommend that instead of just talking about the progress that's being made and letting Congress know about that, you have to also talk about the challenges. And that also can be helpful when you're looking at trying to get the finances and the resources to be able to overcome some of these challenges. So we made a recommendation that the CARB task force report out on these barriers and any steps that they're trying to undertake to overcome these significant barriers. And HHS, as lead of the task force, agreed with that recommendation, and they reported to us in October that they were taking steps to overcome or to put that in its next annual report, which I believe we're on the 5th one, and the plan ends in 2020, and assume that they'll take that action going forward with the new plan that has come out. I want to take a minute to talk a little bit about, as Tim had mentioned, One Health is extremely important, and GAO has other bodies of work. Clearly, we can't go through everything that we've discussed today in the small time that we have. So our point today was to go ahead and to make you aware of some of our other work. We do have a large body of work, not only on the public health side, but also looking at what we're doing in food animals. I wish we could say the same for looking at aquaculture. We do not. These are traditional food animals. We also do not have work related to fungi or to water and other One Health things that are important to do, pets as well. But one of the, so yeah, I think for the sake of time, we'll leave it there. But I do believe that Dr. Flynn provided an update on where we stand in the food animal world in your last meeting that you had. So if you have any questions, we'd be happy to entertain that as well. So, and as the sun is coming around the corner, I didn't anticipate this, sorry. I'm trying to move slightly as the sun's coming around. So to conclude, obviously antibiotic resistance is a serious global health concern. As Tim says, he kind of calls it the silent pandemic that is ongoing right now. And the US federal agencies have taken steps to improve surveillance and diagnostic testing, develop new treatments, and promote stewardship. However, more is needed. We believe that by implementing the 8 recommendations, including the 2 that you see up here that I just talked about, will make progress. It's certainly not going to resolve the problem. This is a large ongoing problem that needs sustained attention, but we believe that at least our report helps bring attention to Congress, and hopefully in a way that provides it in lay terms that they might be able to understand. I think one thing that's so challenging about antibiotic resistance is that just the general public and understanding it. They don't see it, it's not tangible. And so that's part of what we hope to convey when we issue our reports. And I also wanted to mention that, Tim talked about COVID-19, and there's so much focus right now on COVID-19. And my hope is that it won't detract from this very important issue on antimicrobial resistance, but instead will open our eyes to the fact that if you take a look at COVID-19, where we have a novel virus, and you look at how quickly we've been able to garner the resources to be able to tackle some monumental challenges, being able to get diagnostic tests out there. Clearly we can do it. And now we're getting down to the point where we're having point of care. Just this morning, Pfizer made an announcement that they believe that by the end of November, the end of this month, that they have a vaccine that's going to be 90% effective, that's going to be able to submit for an emergency use authorization. That's huge. So that tells us that we can tackle monumental problems if we have enough sustained attention and support. And so we do have a window of opportunity here. And on that note, I'm going to stop there and ask if anyone has any questions for Tim and me.
Give me a second to unmute there. Yeah, thank you very much. Those presentations are really helpful. I know Andy Stragachis has a question. If there are others, if you put them in the chat, that will allow Joanne and I to kind of monitor those. But Andy, go ahead.
Yeah, hi. Thank you very much for that interesting presentation and report. I want to ask a question about surveillance, recognizing it's not easy. But I do want to get a better understanding as to whether or not the fine work of GAO examined the potential for use of other federal health databases to address some of the problems acknowledged in terms of representation, visibility, and accessibility, specifically databases from places like the VA or DOD, and even from the private sector. Was that within the scope of the assessment? And if so, what insights might you share as far as improving accessibility, even beyond aggregate level data, to get a better understanding of the scope and magnitude of AMR? Thank you very much.
Mary, I'll start that one. And then we do have, as Mary mentioned, this is Tim. We do have 3 of our assistant directors that helped us in the study. This is a big study GA did that can chime in on this, but I'll just start. It's a great question, Andy. Thank you for it. The short answer is in the scope, we did not look at all the VA, the various assets. It wasn't a survey in terms of looking at every possible database. So I think that if the hypothesis is, are there sort of data insights that can be quite useful to surveillance, I think the short answer is, I'm sure, I think like a data scientist. I manage our analytics team at GAO, so I'm all about that particular thing, but our scope did not cover that. I will say though, that even within our scope and within CDC itself, still a lack of coordination and data sharing within even CDC. So coordination is one of those things that GAO does a lot of work on. Our batting average, as it were, on recommendations that deal with complex coordination is not high, because we like to track ourselves on saying, hey, we recommend that folks do this, and do they actually do it? Because ultimately coordination is easy to say, but hard to do. And so I think it's a big issue. I think it's how to get it done is critical. Maybe it's just an increased imperative or focus or leadership that could do that, because I would agree with you optimistically and cautiously that there's probably some things out there that can help this problem. Mary, do you want to add to that, or anyone?
Yeah, and I would just add that, I do think it's important to look at VA and DoD and other agencies, because they do have different tools at their disposal.
Right. VA is a treasure trove of data because they have to keep their data by statute for 8 decades. So, I mean, if you think about the longitudinality, no one has that in the federal government. So it's a well put question. It didn't fit within the bounds, even though I tried to, again, have that large aperture look at this.
So I know we have to move on in just a few minutes to our next presentation, but I have 2 questions for you, Tim and Mary. The first one, I think sorry, one moment. The first one is probably the longer one to answer. It's what needs to be enlarged in stewardship programs. So what do you see are the bottlenecks to implementing good stewardship? That question is coming from Lefteris Milanakos, one of our committee members. Lefteris, please let me know if I'm not representing it correctly. But the question was about the bottlenecks to effective stewardship programs. The other question, I'm going to say it second because I think it can probably be answered more quickly, is about if your report didn't cover issues related to aquaculture and water. Right. I think you've probably seen that one. Yeah.
Right. So I'll start, and then Mary fill in any gaps on that. And just in terms of the purview, we have from an issue area, we do have purview over the issue area. It's just that we're going to have purview over those federal agencies that have a role in that issue in that area. Like we wouldn't have oversight powers over the aquaculture industry per se, but the regulatory bodies or things like that, EPA and so on, and others, we would. So that's something that could be for future work, as Mary was saying. In terms of the stewardship, one of the basic things, I'll just kick it off and say one of the key things is on the lack of research or insight from the breakpoints that we're talking about. Prescribing physicians don't know how much and which ones and at what timing and things like that. And so there are some key basic R&D questions that with a directed program, I think could answer and help provide for at least an insight-based stewardship. Even if we succeed in diagnostic testing, for example, just the ability to detect or to determine, distinguish between bacterial and viral infections means that if it's a viral infection, then don't prescribe an antibiotic, right? We need to think antivirals or whatever. So even just that basic step could go, I believe, would go a long way as a basis for a stewardship program. So Mary, do you want to say anything on that?
Yeah, thank you, Tim. Yeah, so with respect to the storage, we had more work related to that. We certainly do have the authority to look at the aquaculture and the water. I mean, gosh, I hope we're taking advantage right now. We're talking about testing waters to look for COVID-19. I mean, I hope that we can go to efficiencies and then also look for resistance. I mean, it's a fantastic opportunity of where an efficiency can be gained. With respect to the bottlenecks for stewardship, I mean, again, the fact that we only have compulsory data coming in from very select facilities is problematic. It would be, although they are getting information from other areas, it's voluntary. If you look at what they are able to do on the international arena, I'm not suggesting by any means that it's what we must do here, but the reason that they can get better data is because they have better compliance. I mean, specifically on the veterinary side, for example, we don't have duration labels on all of our animal feed here, and yet that would be unheard of overseas in some of the European countries where they're doing that work. And some of the other bottlenecks, for example, it's with respect to the stewardship, if they would be able to at what some of the ideas are that are being done on the animal side, most of the antibiotics, the majority are being used in the animal industry. And so if they would be open to some of the things that are being done overseas, I think that there are some opportunities to improve stewardship there.
Thank you both so much for that talk. And also thank you for the wonderful GAO report, which we've all gone over and is just such a great resource for this topic. And I know we have more time for questions coming up at the end, but I just wanted to thank you as we move on to the next presentation from Ramanand Lakshminarayan from the Center for Disease Dynamics. And sorry, Ramanand, I'm making Dynamics, Economics, and Policy. I know he was on bright and early. And there you are. As long as your mic is active, you should be able to share your screen.
Here we go. So make this full screen. Okay, thanks, Julian, and thanks to the committee and the chair for inviting me to present. I was asked to speak on convergence and antimicrobial use, excuse me, and factors influencing resistance. So, you know, that's really two topics. But I thought I'd start with first pointing out that you know, when we talk about antimicrobial use, antimicrobial use is really, you know, many things combined into one. So we'll have to unpack it a little bit. But the first thing that's interesting about antimicrobial use, even looking at the United States, is that there's tremendous variation, tremendous heterogeneity across the country with respect to antimicrobial use. The average person in Alaska or California uses about half the antibiotics, you know, per capita as someone in Tennessee or Kentucky or West Virginia, which happen to be the places that have the most antibiotic consumption. And, you know, the other states are somewhere in between. Now, if you take the US as a whole, the average per capita consumption, and these are usually measured in defined daily doses per, you know, per thousand population or antibiotic prescriptions per thousand population. You can take your pick there, and each of them have pros and cons. The average person in the United States consumes about twice the antibiotics as someone in Sweden. And these variations are not explained by need per se. In other words, the average person in the United States is not twice as sick as the average person in Sweden, and therefore requiring antibiotics. And similarly for someone in Washington, Oregon, California, compared to someone in Kentucky or Tennessee. So there's clearly lots of other factors that drive variation in antibiotic consumption, but this is true around the world as well. But if you just look at the US alone, you know, one of the things that interestingly drives this variation is really provider density. So in earlier work, we found that geographical variation in prescribing is driven in part by the number of physician offices per capita. So for a 1 standard deviation in the number of physician offices per capita, there was a 25.9% increases in prescriptions per capita. Now, this is not a US only phenomenon. We've seen this in other countries in Latin America and also in Taiwan, where they have extremely good data on antibiotic prescribing. So, you know, the things that drive prescribing tend to be more economic and cultural factors. They tend not to be the need from a clinical perspective. So I think that's the first thing to keep in mind. If you look globally, there's been a huge amount of variation across countries. And the second paper that came out a few years ago, well, actually 2 years ago, found there was significant difference across countries, but also a convergence in antibiotic consumption. I'll just speak to what that really is. If you look at consumption by country from 2000 to 2015, global consumption went up by about 70%. Most of that increase was in the developing world, and it happened to be in the countries, in the BRICS countries, Brazil, Russia, India, China, and South Africa. But there were some countries which had, increases, like for instance, Turkey, huge increase, and also Vietnam, for instance, and large decreases in countries that previously had consumed a lot of antibiotics, Japan being a good example. But you see these other countries in the dark red, whether it's Brazil or Saudi Arabia, there have been some significant increases in consumption. And if you look at defined daily doses per 1,000 inhabitants per day in 2015, which is the last year of the study, you can see that some countries, Turkey or Tunisia, consumed about 4 or 5 times the amount of antibiotics as Mexico or French West Africa or Colombia. Now, China happens to consume a lot of antibiotics in the animal sector, but on a per capita basis, not so much in the human sector. India is somewhere higher there, but India and China, having large populations, end up consuming a lot. And if you look for the United States, I forget it, somewhere here it is. So it's definitely on the higher side, although some countries, particularly in the Middle East, but also in Europe, actually consume more on a per capita basis. Now, a striking feature around that period, 2000 to 2015, is that antimicrobial consumption is converging around the world. Consumption in high-income countries has been fairly stable, perhaps declining a little bit. Consumption in upper middle-income countries, which looked a lot more like lower middle-income countries at the beginning of the period, has sort of caught up so that it looks much more like high-income countries at the end of it. And the upper middle-income countries include China. It certainly includes countries like Indonesia, Malaysia. A lot of the Asian countries are upper middle-income countries. The low and lower middle-income countries are, India, much of, large parts of Africa. A lot of Latin America happens to be in the upper middle-income world, but some in the lower middle-income world as well. And you can see that there's been significant increases there as well. So you're going from about 6 or 7 defined daily doses per 1,000 inhabitants, and you're going up to almost twice as much. And if you look at, again, changes over time, you can see the same thing as you saw on the left side, except you're seeing it here. And you can see the changes by country, which is Russia, huge increase there, Brazil, Turkey, and all others, all going up significant amounts. Similarly, India, China, Pakistan, all others, significant increases in these countries. Now, this convergence means that we can project forward to 2030. And if we see convergence continuing, we're going to see that all the countries will sort of cap out where the high income countries are, which, if you think about it, there's some amount of good news there, which is it'll be about, 60 billion defined daily doses. And if we forecast, up from there, it'll probably be twice as much. And if there's no future growth, it'll be about, a little less, about 20% less. So the convergence, a lot of it has already happened. But if these countries continue to grow, there's no reason why on a per capita basis, they couldn't exceed what is happening even in the current high income world. Now, the countries with the highest increase in consumptions happen to be India, which is because it's a large country, similarly for China. And again, like I said, the other big countries are Turkey, Brazil, Vietnam, Pakistan, Egypt. You can see that a lot of it is correlated with just income. People who previously never had access to antibiotics are now consuming antibiotics for the simple reason that they always wanted to, but could never afford it. And economic prosperity, along with population growth, is really the biggest driver of antibiotic consumption. I mean, rising incomes are going to do that anyway. If you look again at the kind of antibiotics that are being used, this is a different study. And what we see here is that, in the high, so the left side shows high-income countries, the right side are low-income and middle-income countries, that a lot of use of penicillins, but of cephalosporins and fluoroquinolones in the high-income world. And if you look at the low-income and middle-income countries, you can see that the penicillins actually are on the slightly on the lower side. And in fact, if you look at things like glycopeptides, all consumption is pretty low. So it's a similar pattern, but you'll see lower levels when it comes to low and middle income countries. Now, when you break it down by the WHO categories, or what are called access, watch, and reserve, I'm sure you're all familiar with it, but basically access are the antibiotics that the World Health Organization says everyone should have access to. Watch are those, and of course should be given out, should be used appropriately. Watch are those which should only be used if the situation warrants it, such as, if the patient, if resistance is going to be high, or if it's really needed there. And the reserve just really should not be used at all. And this is how the guidelines recommend how to use the antibiotics, which is a really easy way to think about it. You can see that the left side, Algeria, South Africa, most of the antibiotics that are used are in the access category. But as you go to the right, you see that countries like India and again, Japan, most of the antibiotics are not in the access category. They're in the watch category. And in the case of India, some which are also in the not recommended category. And in Japan's case, it's in the reserve category. So just to go back to the previous slides, I'm not going to go back, but just keep in mind that aggregate consumption and defined daily doses per capita and an aggregate basis mask also differences in the kinds of antibiotics that are being used. And so we want to pay attention to variations across countries. We want to pay attention to variations within countries. And then we also want to pay attention to variations in the kinds of antibiotics being consumed. So there is, again, one country out here, I think that's Egypt, where a lot of antibiotics that are not recommended are consumed. These tend to be irrational combinations of antibiotics. That, in the case of India, will start going down because many of these have been banned, but companies have made them over many years, which are combinations that should have never been made in the first place. And if you go to the access category, it's sort of so the top quadrant is the left is access. This is the watch, and this is the ratio of access to watch in different countries. And you can see that, so these are high income overall, and then lower middle income, so that's upper middle and lower middle. So you can see that the access category over time, going from 2000 to 2015, has not changed a huge amount. What has changed has been that the watch category antibiotics are now being consumed a lot more. So now this is an interesting picture, because earlier I told you that a lot of the antibiotic consumption has increased between 2000 and 2015, but now we realize that much of that increase is actually in antibiotics that are not really recommended for to being widely available. Now, obviously, resistance patterns are different in different countries, so each country has to do what makes sense for them. But that also indicates that there's a combination of resistance being high, but also a lot of inappropriate use of these watch antibiotics. And as a result, you have plot number C, where the ratio of access to watch antibiotics has been going down over time, not what we'd like to see at all. And all this is just the same thing in colors, which are change in consumption of access antibiotics and watch antibiotics. These are A and B, and expressed in in DIDs, and basically you can see that there's reductions in some countries, but in many countries there's actually been an increase. So the warmer colors point to an increase. Now, the proportion of countries that met the WHO target of at least 60% of access antibiotics in total consumption, you can see that that's, it's going in the opposite direction of where it really should be. So we really should have been seeing a lot more of the ones that were meeting the WHO target of 60% access antibiotics and total antibiotic consumption. Now, a lot of it is also being, what's going on in a lot of these countries is also the National Action Plan. These are data from the WHO, which show that many countries have put in place national action plans, but they don't necessarily have funding sources that have been identified. Of course, some have no action plan at all, but many of them have action plans under development, or they've just been developed, but they haven't really been operationalized. Some countries have obviously operationalized it. So the dark greens are the ones which are where there's work that's already happening, which is promising. But the lighter green are the ones where the plan has been approved, but there's no operational plan and monitoring arrangements, which actually accounts for a large part of the world, which is disappointing because we had this UN General Assembly high-level meeting back in 2016, and it's almost 4 years from now. Actually, it's more than 4 years from now, and we haven't seen nearly the progress that we would have wanted to see. Now, these are slightly older data showing, for instance, carbapenem sales. And carbapenem sales in some countries are vastly higher than in some others and have been increasing over time, whether India, Pakistan, or Egypt. And these point to the easy availability of antibiotics over the counter. Now, carbapenem consumption has also increased in European countries, perhaps driven by a concern about resistance. So one of the challenges with antibiotic resistance is that it is used as a marketing tool by pharma companies to be able to push antibiotics that are probably on the watch or the reserve list, and therefore are not indicated for that particular patient. But the fear of drug resistance drives people towards antibiotics that they really shouldn't be using as well. Now, having antibiotics alone is not sufficient. They must be used. Now, penicillin is effective, but it's not widely available in India, for instance. So in India, you can walk into any sort of a pharmacy, and you'll be hard pressed to find even penicillin G. You can get carbapenems, you can get you can get colistin over the counter, but you probably won't be able to get penicillin, even though penicillin is extremely effective for pneumococcal pneumonia. And there's a lot to be done in terms of avoidable pneumonia deaths by improving antibiotic access. So as much we're concerned about excessive antibiotic consumption, we want to remember that more people die because of lack of access to antibiotics today than due to resistance. And so increasing access to antibiotics is still an agenda that should be pursued. And I don't want the takeaway from this to be that the consumption is increasing and too high, and therefore we need to curtail antibiotic access. Far from it. We need to improve antibiotic access, but to appropriate antibiotic choices, and that's the tough balance. How do you save all these lives, but at the same time not push antibiotics that are creating resistance? Now, if you look at drivers of antibiotic consumption, the flu season is a very important one. Globally, in the Northern Hemisphere, the winter months, especially December, January, February, are the peak months for consumption. And the opposite is true in the Southern Hemisphere. This is obviously inappropriate because the flu season really is not supposed to be driving antibiotic consumption, but it does. And in fact, in the United States, in a paper that we wrote quite a few years back, we found that if you have data on antibiotic sales, you can almost perfectly predict influenza in the US if you're trying to fit ILI data to antibiotic sales data. So this again is disappointing, but this is the truth of it, which is that a lot of antibiotics are used during the flu season. And in fact, I think this year, this paper was published, which showed that even after you control for a lot of other factors, a 10 percentage point increase in the influenza vaccination rate was associated with a 6.5% decrease in antibiotic use, indicating that first of all, having the flu actually does drive antibiotic consumption, and second, it can be countered with a flu vaccine. So with a flu vaccine, you can decrease antibiotic use, and you can also have fewer antibiotic prescriptions per 1,000 individuals. And this effect is greatest in the pediatric population and also in the elderly population. No surprise there, because these are the two populations that are responsible for the most amount of antibiotics. Now, if you think of antibiotic use and resistance, use being one of the big drivers of resistance. Now, this is a famous paper by Herman Goossens and others, way back in 2005, where they looked at resistance, total antibiotic use in 26 European countries. And they basically did this very, crude ecological plot, just plotting this data of outpatient use of penicillin, and then looked at penicillin non-susceptible strep pneumoniae, and they found, this was a very nice fit. Obviously, France helped that fit a significant amount, but this seemed to indicate that use was a responsible factor for resistance, something that we know from, first principles of ecology. And at one end of the scale was France, and the other end of the scale was the Netherlands. Now, this has been confirmed in a number of studies in the developed world since then. This was a study by a student of mine, again, looking at antibiotic prescriptions and resistance, and finding that one lagged the other by just about 2 months. We're looking at aminopenicillins or macrolides, and you see this significant variation, seasonal variation, and these actually drive resistance. And this has been done in other studies as well, looking at seasonality of prescribing depending, on the kind of antibiotic. And the interesting thing is that you find this effect in the case of antibiotics, but you don't really find the seasonality associated with viruses, which is the way it should be. So this is a bit of a check to see that this is actually truly related to what we're looking for. Now, the same effect has not been found, interestingly, in developing countries. So this is admittedly an ecological analysis, which we published a couple of years back. But what we found here was that consumption was, if anything, it's almost like just a flat line, if anything, slightly going down when you look at resistance. So consumption was not the biggest driver of resistance. Many other things were, including, it was correlated with governance, with health expenditures, with GDP per capita, with infrastructure, indicating that it's not just sheer selection pressure, that all of the factors that are able to transmit resistance, and we're guessing that a lot of these are related to the transmission of resistance because they don't have water and sanitation or up to snuff, or ways of curtailing transmission, that selection of resistance alone is not what's driving resistance across the population. It's the ability to transmit resistance that's really causing resistance to be as widespread a phenomenon. Now, again, this is an ecological study with all of the caveats that come with ecological studies, but seems to indicate that the clean relationship that we observe in high-income countries between antibiotic consumption and resistance, breaks down in other geographies, which means that it's a much more complex picture when you think about factors driving resistance in low and middle income countries. So that's all I have for you today. So I'll just stop here, and I'm happy to take questions. And of course, the data are all at CDEP's website at resistancemap.org. And you can create your own maps of resistance and of antibiotic consumption for a number of these countries. So thank you, Guy. Thanks for having me.
Thank you, Ramadan. I have a quick question regarding, have you mapped either consumption or resistance to implementation of public health measures such as, just a minute, start my video, such as childhood vaccination rates or something, any of the public health measures?
We've tried to do that. In fact, we had childhood vaccination rates in that last paper that I just showed you, the one which showed that health expenditures and governance indicators were correlated with antibiotic resistance. So we did put all of that into that analysis. And it turns out that it didn't have a direct impact. It turned out to be much more just the infrastructure. So the infrastructure was water and sanitation, by the way. So it does drive resistance, and it's a bigger driver of resistance than just consumption.
Yeah, okay, thank you.
So we have time for a few more questions, and
Jillian, could I ask a question?
please do.
Thanks, Ramadan. Really very, very nice overview. Question, does a requirement for a prescription make any difference? Is there any benefit to pushing for requirements for prescriptions? In many countries, most antibiotics can be easily obtained over the counter.
It's true in the US as well. It's easy to obtain an antibiotic. So in a sense, the prescription is only a barrier. It's almost like a toll fee to getting an access to an antibiotic. It is not clear that physicians are good stewards of antibiotics in the sense that it's not clear that countries which have a prescription only policy. So in fact, if you look at the data across the world in terms of where the highest rates of antibiotic consumption are, they tend to be in places that actually require a prescription. The US is one, most of Europe is another example, and also, Japan, for instance. So the prescribing is just a barrier. And my concern would be that in many developing countries, it poses an insurmountable challenge for people who really need antibiotics, particularly, very quickly, because their child might be sick, and saying that you can only get it through a doctor could put a lot of lives at risk. So for those populations, we really just need to make antibiotics a lot more accessible. Not all of them, stuff like penicillin or some of the access category antibiotics. But there's nothing that I've seen to indicate that that's really a good way to solve this problem, because we need some sensible barrier between us and the antibiotic, but it's not clear that physicians provide that that filter in the way that we imagine that they do.
We have some people have sent other questions in the chat, so I am just.
Let me read that off.
Sorry? Oh, no, I think just to me, Ramadan. So I was going to ask you this. Next one is coming from Andy Stragakis. If you could describe the improvements that you see being needed in data collection or methods to measure consumption and use.
Well, Andy, I'm hoping that you're going to be doing a lot more of that within the context of your project. I think we are highly dependent on just a few private sector players for getting data on antibiotic consumption. And particularly outside of Europe, the Europeans have their act together. We don't have a good system in the US to collect consumption data, particularly in hospitals. And that's true around the world as well. Now, there have been sort of more community type surveys. Wellcome Trust has funded one through a project called Abacus. But overall, we don't have consistent systems for these, and we've not invested in it in the same way that we've tried to make investments in gathering data on antibiotic resistance. The Fleming Fund, as part of one of the pieces, which I know you're familiar with, in the regional grants, has tried to get retrospective data on antibiotic consumption. But the data are really patchy, to be honest. So it's a big gap that remains to be filled. And until that happens, we're dependent on these private sector data.
May I ask a question?
Yes, please, please.
Thank you. This was very insightful. What is the correlation between prescribing an antibiotic and really using it? Have you looked into that? I remember my mother from Greece. You would open her, before she passed, you would open her drawers and augmentin would fall on your head. Like, I remember, and this is funny, when I moved to this country from Greece, half of my luggage was antibiotics just in case I get. So can you help me how much of this consumption is really used and how much it drives here, please? Thank you.
Thanks for that question. I can sympathize with that because my mother did exactly the same thing, and my father was a physician. So, and so my family would always joke that my mother was a half physician, which is the most dangerous kind of physician of all, right? So, I've had the same experience. There are two things. One is, of course, polypharmacy and having access to antibiotics without a prescription in the same way that Mary just asked. The other part is people taking incomplete doses, keeping the rest of it for a situation that could arise in the future, and that's pretty common, particularly in Anglophone African countries. For some reason, there's a culture of not doing that in the Francophone countries as much, but certainly true in the Anglophone countries. And this is not just for antibiotics; it's true for antimalarials and other things, where people actually have the habit of keeping antibiotics at home, and this has been found in quite a few surveys. Now, there's really, it really is a challenge to figure out how to get people to not do this, because again, we're trying to solve an access problem. Because we've not solved the access problem in a sensible way, it's starting to get solved, interestingly, through COVID and telehealth. The fact that healthcare is now available over a phone, over a video chat from a distance. And I think that's opening up healthcare in some ways that it wouldn't have before. I observed that in India, for instance. But overall, until we fix the problem of getting access to appropriate primary care when people need it, we're going to continue to see this sort of thing. And beyond what you're saying is also there are many what are called rural medical practitioners in Africa and India. It's a nice way of saying there are lots of quacks, and then the quacks outnumber the medically trained physicians by a factor of something like 4 to 1 or 5 to 1, and they all use antibiotics. I mean, in fact, they'll use an injection of saline or of steroids or of antibiotics just as a pick-me-up kind of a thing. And so there are many of these avenues which antibiotics get out and cause a lot of damage.
So it says I'm unmuted. I don't know. Can you hear me?
Yeah, I can hear you.
Okay. There's time for this, I think, one last question. And Mary Wilson, Mary, you may feel that this has already been answered, but was asking about what data you have on inappropriate use and access in low middle income countries.
This question of inappropriate use is a really difficult one to answer, even for the US, even in really good data systems, because how do you define inappropriate use? In studies that we have done at some of the best institutions in the United States, what we found is that something like 60% of people in these hospitals. I mean, so let's start at the very best, right? So then we'll get to the very not so great. Even in the best facilities in the United States, only about 60% get a culture before they get an antibiotic. 40% just do not get a culture at all. And even of the 60% who get a culture, most of those who have a negative culture are not taken off their antibiotics. So de-escalation is actually quite rare. So unless we can set a standard or protocol for what appropriate consumption looks like in the best of settings where we have the best trained physicians and the IT systems and so forth, what hope do we have of doing that in the developing world or even in the US, outside of the hospitals? I think we've not done a really good job in terms of simplifying our definitions of what appropriate use is, and even in hospital settings. And I think we should start from hospital settings before we venture into the community settings. And In fact, I was just looking at a paper that for a review just a few weeks ago, which had the same issue, which is trying to figure out what is inappropriate or suboptimal prescribing, even in the US, is not that easy. It's very challenging, and the literature has just not been able to grapple with defining what that looks like.
Thank you, Ramadan. Ramadan, thank you so much.
Thanks for having me, Julian.
And I really appreciate you staying up. It looks pretty late out where you are.
It's all right.
So we here are gonna everybody take a 10-minute break, and then we'll be back for our next presentation from Susan Bright of FDA. And we'll see you all soon. Thank you. Thank you, everybody. Welcome back from that brief break. Our next presentation is from Susan Bright from the Center for Veterinary Medicine at FDA. Susan, I don't see you on my first screen, but I know you're here. Oh, there you are, Susan.
There I am.
So, okay, there, I finally see you. So you have the floor if you'd like to share your screen. Thank you for being here.
Yeah, let's see. I think we are here. Are you able to see my slides?
Yes, they're good. Everything's
Okay.
Yeah.
Okay, just give me one moment. Okay, everything's still okay there?
Perfect. Thank you.
Great, thank you. Just had to set it up here. Good afternoon, everyone, or good morning or good evening. Also, just want to thank you for inviting CBM back to present some additional information to the committee about measuring the impacts of FDA's actions to promote judicious use and antimicrobial use in veterinary medicine. So today I was just basically going to first briefly review some of the changes that have already been implemented by FDA Guidance for Industry, or GFI number 209 and 213. Most of you are probably already aware of this, so I'll just keep that part brief. And then also just wanted to say that we know that tracking progress is essential to measure our impacts from these policy changes, and also to help guide any future activities. So some of the data that we think are needed to help assess these impacts of those changes include data on antimicrobial use, data on antimicrobial resistance, information about animal health. So just kind of considering all sorts of different aspects. So as you know, GFI 209 was published in 2012, and it describes CBM's overall policy direction for the judicious use of medically important antimicrobials in food-producing animals. And it did focus on two key principles that basically in food-producing animals, medically important antimicrobials should be limited to those that are necessary to ensure animal health. So in other words, no production uses and that type of thing. And then the other key principle was that antimicrobial use should be under veterinary oversight. So following on with that publication of GFI 209, GFI 213 was published, I believe, in 2013. And it went on to basically provide just a more detailed guidance and a timeline for implementation of the key principles described in 209. It utilized a voluntary approach, and basically, again, the key was that we wanted to eliminate the production uses, meaning those uses for growth promotion and improved feed efficiency. And we also wanted to change the marketing status from either over-the-counter to prescription for products that were administered in water, or from OTC to Veterinary Feed Directive, or VFD, and that would be for feed administered medically important antimicrobials. And by October of 2015, some of the work that we needed to do to amend the VFD regulation was in effect by that time. And then ultimately by January 1st of 2017, all feed and water uses of medically important antimicrobials in food producing animals do require veterinary oversight and can no longer be legally used for production purposes. So in terms of what we want to do and how we've been, approaching measuring impact of those changes. Just want to reiterate that our primary goal is to support implementation of judicious antimicrobial use and stewardship practices in veterinary settings. And we believe that to kind of assess those impacts, we actually need a pretty broad set of data. Currently, we do report annual antimicrobial sales data and antimicrobial resistance data through the NARMS and VetLearn programs. NARMS is the National Antimicrobial Resistance Monitoring System, and VetLearn is FDA's Veterinary Laboratory Investigation and Response Network. In addition to those data sources, we also feel that information about on-farm antimicrobial use practices and on-farm antimicrobial resistance, information about animal health and animal populations, as well as, again, antimicrobial resistance data for both pathogenic foodborne bacteria as well as commensal bacteria are all parts of the picture that should be evaluated when trying to assess impacts of the changes that we have put in place. We know here, that antimicrobial sales do not reflect actual antimicrobial use on farms. I'll talk about that here in just a moment, but even so, we can say that recently observed sales volume reductions do certainly provide some sort of an indicator that ongoing efforts to support stewardship are having an impact. So speaking of sales, I just wanted to briefly show this slide. I wasn't really going to go over any of the background for the sales reporting requirement other than just to say that FDA has been collecting and required to report on medically important antimicrobial sales data for use in food producing animals since 2009. And our most recent report was for 2018 data. Also, since 2016, just so you're aware, there was also a requirement added that antimicrobial drug sponsors will need to basically estimate the amount of antimicrobial sales per species. So for the 4 major food producing species. So that started in 2016. And so really this chart is just an idea of showing you kind of some trends. Again, this is total overall sales of all medically important antimicrobials. This chart is not broken down by class, drug class or anything like that. But you can see there between 2016 and 2017, kind of in that time frame where the implementation of GFI 213 was occurring, there was actually a 33% decrease in overall sales of all medically important antimicrobials. Now, the next line over between 2017 and 2018, we do see there was a small increase, although still compared to prior years, that increase or that amount in 2018 was still about 21% less than our initial year of reporting in 2009, and still about 38% less than our peak year of sales in 2015. Now, possible reasons for the increase between 2017 and 18 could relate to a few different things. There could be changes in animal population numbers. There could be changes in animal disease incidence, which then subsequently would lead to changes in the need for antimicrobial therapies in animal populations. So we really would expect some kind of small fluctuations from year to year, depending on these and potentially other factors like economics or drug availability. So, and this is kind of part of the reason why, just a straight target of reducing sales has not really been necessarily a goal of ours. We recognize that the factors that go into antimicrobial use and the factors that affect those factors. So a lot of different things. But anyway, I also just wanted to say on this chart, presenting the sales data in this way is a fairly crude way of presenting the data because it doesn't really take drug potency into account in terms of dosing and stuff like that. But it is good for just giving a big balcony level, big picture view. So on the next slide, I did kind of provide just a couple of examples of ways that sales data are presented in the annual sales summary report that do provide for an additional breakdown. So on the left, we show, this was from the 2018 sales report, we show how we break it down by drug class. And clearly here you can see among the medically important antimicrobials, the tetracyclines are the highest volume in sales, and they have been pretty much since we started monitoring this. And then the second highest volume in sales, though, is for the ionophores, which are not actually considered medically important. But going back to the tetracyclines, they represent about, in 2018 anyway, they represented about 66% of all medically important antimicrobial sales. And I believe between 2016 and 18, the tetracyclines had decreased by about a little over 30%. So, and then on the right, I wanted to just show another example of a type of chart that we are showing, which is basically showing the species-specific estimated sales. So again, as I mentioned in 2016, we started having the drug sponsors estimate how much product they thought was going into particular species. And so and that would be the 4 major food producing species. And then we do have kind of an other category that's for everything else. So we can see in this chart too that there were variable decreases across all species for the total estimated sales between 2016 and 2017. And even between 2016 and 2018, there were substantial differences between those years. Again, between 2017 and 18, there were small increases for cattle and swine, a continued decrease for chickens, and about no change for turkeys. So, but really kind of an important limitation of sales data is that they don't represent how much or in what way the drugs are actually used in animals. For example, for what diseases, at what doses and at what durations. And sales data also don't really take into account fluctuations. I kind of alluded to this earlier, fluctuations in animal populations or changes in animal disease prevalence or incidence and things like that. So, and for those reasons too, or partly, sales are not necessarily helpful to kind of assess appropriate use, as someone mentioned earlier, assess appropriate or inappropriate use or stewardship. So sales are volume basically. So just wanted to mention that. And then, so knowing that those limitations of the sales data, it is important certainly to try to gather data on how antimicrobials are used on farms. And, that would be a better source of data to help us assess stewardship and could also help us look at, maybe specific use practices and how they might be linked to changes in resistance, things like that. So on this slide, I just have a few of the US government efforts related to collecting antimicrobial use data, and they include the USDA APHIS National Animal Health Monitoring System, or NAMS, and our Fda Cbm Cooperative Agreements. So just a brief note on the USDA APHIS projects. So USDA APHIS essentially conducts periodic national surveys in which they include a lot of different questions. They usually do a needs assessment for the production group that is being assessed. But they may include questions though about antimicrobial use practices, and they also sometimes will collect biological samples, usually fecal samples for antimicrobial susceptibility testing. These surveys are conducted only every 5 to 10 years for each commodity group, but they do publish quite comprehensive reports of those survey results. And then in 2017, NOMS did conduct antimicrobial use and stewardship focused surveys on beef feedlots and on swine operations, and they collected information about antimicrobial use practices in these settings for 2016. So the reports for both of those categories are posted on NOM's website. But I did want to talk a little bit just about the Fda Cbm Cooperative Agreements. In 2016, we issued a funding opportunity announcement and request for applications for projects that we wanted to be able to pilot methodologies for collecting on-farm antimicrobial use data. And these were awards were in the form of cooperative agreements. And we requested proposals that would really provide detailed data that would reflect actual on-farm use practices for cattle, swine, chickens, and turkeys. And we wanted them to be able to really pilot methodologies for collecting and summarizing and reporting that type of data. We did request that they would be able to leverage any existing systems, and also wanted them to be able to incorporate strategies to protect the identities of any farmers or producers that were contributing information. So 2 cooperative agreements were awarded. Characteristics of antimicrobial use in beef feedlots and dairies, and antimicrobial use data collection in U.S. poultry and swine production. And basically, each of those 2 projects have taken a little different approach appropriate to the represented sector. And they have really been able to demonstrate that really no one metric likely fits all. It is important to consider sector-specific settings, production factors, and other factors like animal populations and disease challenges. So these 2 cooperative agreements are funded through 2021, and then we'll plan to take information gained from those to build on and hopefully be able to develop in some collaborative way a strategy to support more long-term data collection. And then just also to mention the last point there, we also have been looking into companion animal issues. So we did just a few months ago issue 2 cooperative agreements which are focusing on antimicrobial use data collection for dogs and cats. I just wanted to show a few examples of data that were collected in the poultry aspect of the FDA cooperative agreement. This was conducted by Dr. Randall Singer and his group, and I have the link to the report there if you want more information. But this was just one chart from a report that he recently had published for the first couple years of data collection. And this was basically just showing, in broiler hatcheries how really we saw significant reductions in the use of gentamicin and penicillin in hatcheries. And even just the percentage of broiler chicks that received any antimicrobials in the hatchery decreased from about 93% to 17% between the years on this chart. So again, you'll need to go to that report and kind of get a better idea of how he determined representativeness, what his methodologies were. I just wanted to kind of show a couple of examples. This is just another example from that same report that was showing some of the data that Dr. Singer and his group collected for various antimicrobials used in broiler feed and water. And then also, again, he did also collect information about turkeys as well, and had begun to collect some information about layers. So, and then the other thing to mention, I guess, is the cattle, swine, and poultry project leads are planning to publish peer-reviewed papers about the initial findings of their projects very soon, actually. It'll be before the end of this year. And it'll be interesting to I hope, to be able to take a look at those, because they really did a great job of describing the various challenges with choosing the appropriate metrics for each sector, the challenges even just with collecting the records and putting them in a form that was usable and analyzable, easily analyzable. And a very common finding was that across all types of systems, the more granular antimicrobial use data desired, the more resource intensive it becomes, of course. Of course, we also do need antimicrobial resistance data to help us assess the impacts of the changes that we have made. I'm sure most of you are familiar with the NARMS program. Since 1996, NARMS has tracked changes in antimicrobial susceptibility of enteric bacteria in ill people through the CDC, in retail meats through the FDA program, and in food animals through the USDA program. So NARMS provides annual summaries of resistance trends and collaborates on epidemiologic and microbiologic research studies across the One Health spectrum. And the NARMS Now website actually includes lots of interactive data displays and much of what includes some of the whole genome sequencing data as well. Some of you may have had the opportunity to listen in to a recent virtual public meeting that NARMS held in October, where they presented their new strategic plan and potential plans for expanding AMR surveillance. Pilot projects are being planned for possible environmental and possible animal feed components, as well as enhancing and maintaining surveillance of AMR and animal pathogens, and additional commodities such as seafood or others. And I don't have it represented on this slide, but the USDA National Animal Health Laboratory Network and the FDA VetLearn program are also conducting AMR pilot projects, I believe since 2017, and they're actually actively collecting and reporting on AMR in selected animal pathogens, such as Mannheimia hemolytica in cattle, Pasteurella multocida in several species and others. And they are also collecting some information for companion animals in those projects as well. Just a few more slides. On this slide, I just kind of wanted to point out that, information about animal population and animal health trends can help provide important context for antimicrobial use and resistance. The USDA agencies are active in monitoring certain aspects of animal populations and certain animal diseases. For example, the National Agricultural Statistics Service typically will publish reports on annual food-producing animal inventories and slaughter numbers. As I mentioned earlier, the NAMS program provide periodic information on the various commodity groups. And USDA APHIS also does have, it's called the National Animal Health Surveillance System, but it focuses on the surveillance of foreign, very important foreign or emerging animal diseases and reportable diseases. But that leaves some gaps related to the routine kind of continuous monitoring of animal diseases that may not be reportable, but may actually be more likely to be setting up the need for therapy with antimicrobials. So a little bit of a gap there. So again, just getting back to assessing the impact of our strategies. As I mentioned earlier, we believe we need to consider a broad set of data, including basically everything in this list here. We are actually, CVM is actually working on putting together a report where we're trying to put together a descriptive report. And hopefully this report will be ready by early 2021. But it is intended to include most of the types of the data that I talked about earlier. And I guess I just wanted to mention that while some advocate for setting antimicrobial sales or use reduction targets, CVM is actually pursuing more of a holistic approach, what we think is a more holistic approach, just trying to identify the most appropriate indicators for assessing changes related to the implementation of policies. And so each of the data sources I reviewed today do have values and limitations. You know, antimicrobial sales, as I mentioned, are valuable because they provide a good indicator of overall quantity of antimicrobials, kind of that big picture view. But their limitation is that they don't represent actual on-farm use. Antimicrobial use data is valuable because, you know, it really provides that information that we need about actual conditions of use, may help us assess stewardship better, and can perhaps give us an opportunity to link use to well, specific use practices to resistance. But a major limitation with antimicrobial use data is that it is very resource intensive, and there's usually limited funding for long-term efforts. And then the information about animal health and populations provides context for antimicrobial use. As I already mentioned, some of the limitations are just, the availability of the type of data that's available. And then for antimicrobial resistance, the value is obviously that very robust resistance data are available through NARMS and other surveillance programs. But one of the limitations is that there are no linkages back to the antimicrobial use aspect of it. So just to summarize, I know I've probably taken more time than I needed to, but in summary, the work on our 5-year AMR plan is ongoing, and specific to the topic of this session, goal 3 of our AMR plan is actually to enhance the monitoring of AMR and antimicrobial use in animals. And, again, we can see that shifts in sales can indicate some progress is being made. But, funding of the cooperative agreements for antimicrobial use and the planned potential expansions of the NARMS program are also important steps that we are taking to try to gather additional data that can kind of help us better assess the impacts of changes in use on antimicrobial stewardship and resistance in animal agriculture. I think that's it. Are there any questions?
So I think we might have the time for just one quick question, and then we can kind of revisit some other questions when we get to the end of the session. And just in the interest of time, I'd like to bring up one from Mary Wilson. She was asking if you could comment on how widely are vaccines used to prevent infection in food-producing animals.
I'm not really sure. Let me stop sharing my screen. I'm not sure if my colleagues from FDA are on Bill or Pat, but so the vaccines are generally regulated and monitored by USDA, which is the Center for Veterinary Biologics. So it's my sense that they are relatively routinely used, but in terms of numbers, I couldn't tell you. I don't, or Bill or Pat on that might have any of that information. I'm not sure if they're.
That's okay.
This is Bill, Susan. I would agree. I think there's, the vaccines are used, but I think they're, they are regulated by USDA, Center for Veterinary Biologics, and probably could get further information from the folks at USDA about whether they have some data on sort of extent to which vaccines are used on a regular basis, but certainly is one of the important factor in terms of extent of vaccine use or other issues related to the availability of effective vaccines for some of the diseases that producers are routinely dealing with on farms.
Mm-hmm.
Thank you both for being here and for being available for questions. As I said, we can come back to questions when we get closer to 2. But for now, I want to thank Susan and also introduce our next speaker is Jay Garland from the Environmental Protection Agency, who I'm not.
Can you hear me, Jillian?
I can hear you, yes. Please feel free to share your screen.
All right. Well, thanks for the invitation. Glad to talk with you today. Just give me a second. Can you see the screen?
Yes, it says it started. There we go. Yes.
You're in the summary now, but I need to get to the start, right? There we go. So thanks for inviting me. And I just want to let you know I'm from the U.S. Office of, the EPA's Office of Research and Development. We're the kind of the research arm of EPA to kind of support the regulatory decisions that US EPA makes. I'm at our labs in Cincinnati, Ohio. So what I want to talk about today, first I want to give you a preface that this is a new research area within both ORD and the office that we support a lot in this work is the Office of Water. And so that's a caveat that in case I'm going to talk a lot about plans and not as much about data, but there is going to be some data as well. First, I want to touch on several more EPA specific research areas. This is related to measurements of AMR in the water cycle, particularly municipal wastewater systems, which we spend a lot of time on overseeing, and then also recreational waters and exposures from recreational water. And then also talk about trying to model and mitigate these environmental exposure risk. Really trying to emphasize that it's not just measuring the hazard, but really trying to approach this from a risk perspective. And then I probably spend the majority of the time talking about a more interagency effort on this, specifically on this surface water effort. And that's related in support of the NARMS program that Susan's just mentioned. So the challenge to this issue is that as opposed to a lot of contaminants in the environment, we're not just talking about the simple attenuation of the target pathogen of concern, but also the movement of the genes and the movement of those genes through mobile genetic elements to other non-target organisms in the environment and perhaps even back. So trying to understand not only the normal attenuation, but what factors are affecting the amplification and transmission of these genes is also critical. And I should add, in addition to that, as opposed to a lot of environmental contaminants of concern, this is a contaminant that is naturally occurring as well, right? In fact, we all realize that a lot of these antibiotics came from the natural environment to start with. So trying to always understand what we're observing in the environment with reference to kind of a background level is important as well as you do this work. As you look at this, the graph on the right, I assume you can probably see the figure on the right. You see my pointer. A couple of the areas specifically that EPA is interested in is the natural environment exposure, as I mentioned, to people, particularly from recreational water use. And those recreational waters can be impacted by both ag and the built environment. And then from the built environment perspective, as I mentioned, this wastewater treatment is something we're very concerned with. And even beyond just normal wastewater treatment, where you're understanding how to optimize best management here to minimize a release to the natural environment, increasingly, there's a lot of interest in looking at water reuse. So actually the kind of the internal loop between people and wastewater, but then also returning back to people's consumption, either for potable or non-potable purposes. So if we turn to the wastewater first, this report on initiatives for addressing antibiotic resistance in the environment, current situation and challenges, this was a white paper that was produced in 2018. I'm going to reference this a couple places, but here they looked at various areas, but one was assessing and improving sanitation and wastewater treatment. Those three main bullets there you see below that, the first one emphasizes what one of the earlier speakers mentions, that where you have poor sanitation, there's increased risk for transmission, and that really drives a lot of risk. And this is not, and it is a global issue. So what happens in terms of transmission in other parts of the world can be important for the U.S. as well. That's obvious. But when we talk about, say, maybe the more advanced treatment systems, trying to understand the potential need for pre-treatment of high strength waste is something that comes up a lot, particularly if hospitals are indeed a high strength or a high strength source within the overall sewer network. You could target pre-treatment before it's released, not just to the environment, but into the sewer network itself. Because once you have large volumes of hundreds of millions of gallons per day at a municipal treatment plant, it's hard to implement the kind of advanced treatment that you'd want to, either involving membrane treatment systems or advanced oxidation and disinfection. So there may be a value in trying to look at some of the high strength treatments, but the question remains, on a mass balance perspective, are they really the source of high strength of the resistance in the sewer network? So some of again, this slide kind of, the next couple slides summarize the EPA specific work on some of these areas. Within wastewater, we are here in Cincinnati, our labs are focused on working with our local sewer district, which has a number of different treatment plants and a very great understanding. Like most large cities in America, they really know the flows and the distribution of those flows throughout their network. So we're trying to work with them, looking at both cultures of ESBL E. coli and vancomycin resistant and urococci loading into the system, and look at the isolates and look for the whole genome sequencing of those isolates. But in addition to that, and you'll see this in a number of the parts of this talk, looking at the environment, in addition to just looking at the isolates, we're also interested in looking at the antimicrobial resistance genes themselves. And we're looking at that through kind of a high throughput PCR panel to really look at a large number of screening of these resistance genes, and also other genes that may be of usefulness for interpreting some of the results. For example, like fecal indicator bacteria. So you can, this is not as important in the wastewater, but is much more important in the surface water, where you're trying to track the source of fecal loading into that system. But even in a domestic wastewater treatment system where there are combined flows, you can get stormwater input to a significant degree and perhaps other fecal sources in addition to just humans. Now, this work is on hold right now. We really got geared up. This was one of the priorities of the Office of Water and the Office of Wastewater Management. Within Office of Water, we were geared up to do this beginning last year, started to do it in January, and then because of COVID, not only was there an initial shutdown of the labs, but really a large-scale shifting of our focus and the very people who were doing this work to focused on SARS-CoV-2 monitoring wastewater. So this actually brings up a lot of linkage, I think, in the future, because there's a much greater appreciation now of the usefulness of looking at wastewater, not only as a contaminant, as it would be in terms of AMR in the environment, but also understanding the wastewater as a way to mirror back to what's going on in the community. And that's indeed what we're doing with SARS-CoV-2, but also I think in the future that both the network that we've built and the connections, even further connections with the utility industry and the Department of Health here locally, state-wise, and with CDC is really building on this. So I think that's a clear area for growth. The other area that I mentioned is recreational water. Again, this is a study, EPA does a great amount of work on recreational water, understanding when to close beach based on indicators of fecal pollution. There was a large study planned in the Gulf Coast beaches this past summer that was put on hold because of the COVID issue, but that will continue hopefully this summer. And as part of the normal water quality parameters and predictors like fecal indicators, both existing bacterial fecal indicators, but emerging viral fecal indicators as well, we're going to build in ESBL coli, in this case MRSA occurrence, into that study to help, again, build the risk models. And speaking of risk models, just want to have one more slide before I talk about the surface water work. Here, this is focused on, we're collaborating on a Water Research Foundation white paper on this building a framework for addressing risk for environmental sources of AMR, really trying to build towards a quantitative risk predictions. And there's two, that's the general framework. The two immediate applications of that we're involved in, one is water reuse, where we're trying to actually build in MRSA risks during showering from reclaimed water, both gray water, source separated hygiene water that might be collected locally at a building or a district scale and treated for reuse, but also could be for black water too, kind of combined toilet flow. Now, that might strike you as, the immediate reaction is kind of the ick factor. And certainly, there are people talking about doing direct potable use of wastewater, and there's certainly interest in these kind of systems as well. So we have built risk models for that reuse, focus on enteric pathogens and exposures through enteric pathogens. In this case, we have also right now building in the risk of opportunistic skin pathogens, not just staph overall, but also MRSA risk in there. And I think one of the key elements of that is typically most of our risk models are built around infections per person per year. Our benchmark usually for acceptable level risk is 10 to the minus fourth infections per person per year, defining acceptable treatment to keep it below that. But in this case, when you're talking about antibiotic resistant infections and the larger health impact there, really moving to a different model of assessing that more disability adjusted life years, where you're really factoring in the magnitude of the infections, not just the number of infections. And then again, with recreational water, that we also want to build models on exposure, initially to ESBL coli, because once we move to surface water, there's a lot of interest in using ESBL coli as a standard method. WHO Tricycle Project focuses on that. So we really want to build that as another early application of this framework. So let's turn now to this national scale surface water effort. And this is a collaboration primarily, through NARMS, but with a number of different agencies, primarily through FDA and CVM that Susan mentioned earlier, and Pat McDermott, who heads the NARMS program, but also scientists from CDC and USDA and EPA really trying to come together to develop this particular plan. And so this again gives background on that same report that I mentioned from the challenges and current situations in antibiotic resistance in the environment. When it comes to environmental waters, those three elements I think are very important as we build, we're trying to really factor in as we build our plan. One is trying to develop a geospatial distribution of resistance to inform risk. So both the geospatial nature of it, but also do it in the sense of building risk models to inform risk, not just the hazard. Secondly, really trying to build a better understanding of sources and selective pressures for amplification and transmission, like I mentioned earlier. And then this overarching issue of really defining and standardize both the sampling and the analytical procedures. So we really, as we build our approach, we're concentrating on those three things in earnest. And then the second block below there, that's extracted from the current NARMS strategic plan, which focuses on using surface water monitoring as an initial environmental component as NARMS expands its One Health approach. So the question is, why water? Well, first off, before we talk about that, this effort of surface water antimicrobial resistance monitoring, the goals of this effort, obviously overall, it's a pilot environmental effort within a One Health focused NARMS, but more specifically than that, we want to really develop a national scale quantitative assessment of AMR and surface water, both as a standardized measure and a library of samples too, to monitor long-term trends. But as I've emphasized earlier, trying to develop the data that's relevant for input of models for AMR risk for various end uses of that water, both recreational, drinking, agricultural, and even when I say water reuse, direct potable reuse or non-potable reuse. And then can we develop a national scale system that does help quantify drivers of occurrence and selective pressures? Understood that a lot of that may be very focused, smaller scale studies, but is there a way to inform some of that through the larger scale national study? And then finally, again, emphasizing the risk perspective, try to do it in a way that we can understand critical control points and assess current and future mitigation. So the question of why water. And this graph here represents the basic answer is because there's multiple inputs to into the watershed level, and can water then be an integrated measure of those various sources? So the graph on this figure on the upper left is estimates what the percentage of base flow of several of the major larger drinking water systems that use surface water as their source, what percentage of that flow is from treated wastewater. And you can see those numbers range from less than 1% to over 15% in the red. And there's a number in between where it's between 5 and 15% of the total flow. So we know that there's a lot of treated wastewater flow in rivers and streams in the US. On the right-hand side, that's the treated wastewater, but you can also see this is a map of the utilities that have combined sewer overflows in the US, where you have raw, untreated wastewater flowing into the surface waters under storm events where you've exceeded the capacity of the municipal treatment plants to treat that. So both of those are human sources, direct human sources from wastewater. And then also the bottom graph, this is a map from a EPA tool called EnvirAtlas. It just maps out the manure applications, animal manure applications at the I think it's at the HUC 12 level, that the large scale watershed level. So the idea here is that we're trying to develop a study to capture these various inputs to the wastewater or to the watershed level. So as you go about designing the study, I know there's a lot on this graph, but I guess the big point I want to get across is as you design the study, you can go big and slow, or maybe small and fast, or maybe a combination thereof. And when I say big or small, I'm talking about the geographical range of the study. And when I'm talking about slow and fast, it's the temporal frequency of sampling. The upper graph on the upper map on the upper right-hand side, that is the EPA National Rivers and Streams Assessment, where we sample 1,800 sites across the U.S. And each one of those points is a probabilistic survey of all the rivers and streams in the U.S. So each one of those points informs a certain amount of river kilometers and allows us to estimate the impacts across the entire, in this case, the study is designed around ecoregions, which are the different colored zones you can see there. A lot of the work of this the study is focused on looking at the biotic impacts in rivers and streams. So really the question is, are these rivers and streams impacted? And obviously, when you're looking at the biotic component, you want to factor in and stratify it by the natural differences in the biome due to just climatic differences and other changes at a biogeographical scale. So we were able to leverage this study during the last cycle to look at the occurrence of certain targeted genes. In this case, just the genes, not targeted pathogens, but just genes. And the graph below this map here, this is INT1, the integrase gene, SOL1, TETW, and BLOTM, their occurrence across, again, estimating across the entire ecoregion because of the probabilistic design. So the benefit of this is that you do get this national scale survey, maybe that you can look at long-term trends, some of the objectives I mentioned earlier. The downside is that this is slow in the nature that those samples are collected first once a year only under base flow conditions. And secondly, we rotate through different types of waters each year. So this is rivers and streams that's done every 5 years. Then we move on to coastal waters and lakes and reservoirs and wetlands. So at its current pace, it's slow because it's only once a year and even really only once every 5 years. But we know, if you go to the bottom, we know that there are many factors that affect what's going on in the watershed. This is a preliminary study, surface water study done in the Chattahoochee River by CDC. And not to get, what here you map out rainfall versus the abundance of both fecal indicator bacteria and resistant organisms. And you can see that when you have rain events, you have C increases, which is not surprising. As I mentioned earlier, CSO events, other rainfall runoff. So how do you capture at the first scale, at the top, how do you capture national scale trends? At the second level, understand what might be some of the enhanced risk under the non-base flow conditions and do it in a faster way. So those are the challenges that we're grappling with right now, and probably trying to design a plan that encompasses both. Have both this maybe national probabilistic survey to meet some of the sub-objectives, but then do some smaller scale studies, watershed scale studies, to really define, going back to one of the original goals here of having very defined approach and having standard methodology and approach to really develop that kind of standard approach at a watershed level. And maybe during our pilot efforts here, look at one or two of those and try to expand that greatly with time. This graph just goes a little bit further in the data, and this gets back to the point I mentioned earlier that when you look at the environment, you want to understand what your reference conditions are. So in the NERSA study that I mentioned, we have the capacity to be able to look at both the reference sites and impacted sites based on the criteria that are listed on the bottom left here: general water quality parameters and riparian or disturbance around the rivers and streams. So we know which ones are kind of reference sites, natural conditions, quote unquote, versus impacted by human activity. And the graphs on the right show for the targets that we used in this study for overall, for the entire US, which is the couplet on the far left, but then for each one of those ecoregions, do you see enhancement of that predictor or that indicator versus the impacted versus reference sites, which indeed you do for integrase 1, which is known to be a really good indicator of stress in the microbiome. We also see it in SOL 1 to a certain extent, but I don't want to get too drilled down the methods here, but it's more about developing and designing the studies so that you have this reference into your analysis. And then just move real quickly to the analytical targets. The top quote is from another separate white paper review by Amy Pruden, one of the leaders in this area, that's emphasized, the need for, right now there's no universally agreed to standard procedure, so we really do need to develop those. That's a priority, but also in the absence of the clear definition of what the priority targets are, to really develop approach that encompasses both culture-based approach, targeted gene analysis, which gives you quantitative measures of those genes, and also because you can develop those high throughput panels where you have those fecal source trackers, which is very, I think, important because you can link the presence of any of the antimicrobial resistance to the specific source of fecal contamination in that watershed. So really see correlation between the different fecal sources and the different ARGs. And then also understand where you may see elevated ARGs independent or at higher than predicted levels from any fecal source, suggesting that those might be conditions that are leading to amplification of those genes in the environment. And then also looking at metagenomics, which allows a deeper view. And I put it in which NARMS is very much into as well. And I'm going to show you a brief data there just next. But this question mark of linking resistant genes to host, that's the key. With the metagenomics, it does give you this deeper view of all of the genetic structure or the genes within these samples, but trying to link the presence of the resistant genes to the host of those is what's very important. And something that there are emerging methods like Hi-C that through cross-linking can allow you to understand maybe physical proximity to get at that. But this data here is from a pilot study that we've done with the CBM and FDA, where we looked at just the reference and the highly impacted sites from the one ecoregion of the Northern Appalachians. The Northern Appalachians is basically the Northeast states, and you can imagine that within that area there are some very highly impacted and also some very good reference sites within the states of New York, Vermont, New Hampshire, et cetera. And so when you look at taxonomic comparison, this is a network analysis of reference versus stress, you can see that there are some shared taxonomic types here, actually very few unique taxonomic types in the reference sites, a whole lot of unique ones to the stress sites. This is probably an indicator of our libraries of the genes and how well they get classified. For the reference sites, there's probably a lot more diversity there. That is, particularly those reference sites, we just don't classify those very well. But it shows you that we see a lot of organisms in these impacted sites that are known to be of more human sources. And then you can also look at the resistance genes. Same kind of story. We're in the stress sites. You see a large, greater abundance of different types of stress of these resistance genes. And I guess going back to that previous slide, this is very useful information. What would be even more useful is if we can link the taxonomic and the resistance data using metagenomics. And that is something I think that will be possible, hopefully over the next several years. It's already been demonstrated within like gut microbiome samples. These may be more complex, certainly, but I think there's potential there. So our timeline for this surface water study, we're really heavily in this right now. We've got these work groups on the design and analytical targets question. We have a summit next week amongst about 40 scientists from those agencies that I mentioned, FDA, USDA, CDC, and EPA. So the idea of that summit is to really define the necessary steps to get to this pilot study, which would be from 22 through 25, with the goal of that pilot study and pilot effort, or studies, perhaps going back to the hybrid approach of big and slow and small and fast, some combination of those. But regardless of this, whatever the specific design, the end goal is to result in a final assessment of is surface water surveillance of value to NARMS? And if so, what's the nature of that long-term moving forward? So that's kind of the summary, just like I mentioned, just both of the work that we're doing inside here to inform Office of Water and EPA, and also this interagency effort on the One Health national scale effort. And glad to take any questions if we have any time.
Thank you. So our time is really tight, but I think we have time for this one question. It's from one of our committee members, Ms. Michelle Superior. And it is asking about manure application to crops, since that's an important agricultural source, if there's been any discussion of the monitoring of manure as part of NARMS.
Yeah, I mean, I think in a couple ways. One, like I mentioned, is that we certainly want to build in indicators of different fecal sources, including animal fecal sources, into the analytical targets that we end up using within the monitoring. And secondly, I think that, again, that kind of gets back to the question of, the manure inputs and rainfall events where you may get more input into the surrounding surface waters, trying to design a study, maybe have focused watershed studies where you can try to get at that question of input from manures or other kinds of runoffs, which you may not see as clearly if you have this, as I mentioned, the NERSA design where you have a probabilistic survey where you may be looking at only once a year under base flow conditions, which are not going to capture those kind of inputs.
Thank you. And so we will have a little bit of time left for questions at the end of the session, but for now, I'd like to introduce Lynn Philby from the Office of Global Affairs at HHS. Thank you, Lynn. I see you're already on. And you have the floor. Thank you for being here.
Thank you. Let me just share my screen real quick.
There we go.
Thank you very much for the invitation. So I would like to start by just telling you a little bit about where I sit in the federal government. I am the AMR team lead for the Office of Global Affairs, and our office is a policy office. So we are the global health diplomats for Health and Human Services. And in that role, we not only advise the Secretary on global health, but we also work closely with all of the HHS family agencies and the wider interagency partners to make sure that we are advancing US equities with our global partners. So I'd like to start by walking you through a timeline of how the US has fit into the global landscape on combating AMR. I see a lot of familiar names in the participant list. So I think many of you are familiar with the CDC threat report that was released in 2013. This really spurred some additional attention at senior leadership levels. And I don't want to imply that work on AMR started in 2013. The Transatlantic Task Force on AMR had been around since 2009. CDC and NIH had both done a substantial amount of work on AMR up until that point. But with White House attention, we were sort of spurred in a new direction. So a couple of things came out of that. President's Council of Advisors on Science and Technology, PCAST, was asked to weigh in on AMR. An interagency policy group was established to work on the National Strategy and Action Plan. And globally, the US was one of the early members of the Alliance of Champions. The Alliance of Champions at the time was 14 health ministers who got together in Geneva and said that they were going to prioritize AMR. And while their first in-person meeting didn't occur till 2015, they really started this work about 2013. It was, and still is, co-led by the UK and Sweden. And the Alliance of Champions really pushed WHO to create the Global Action Plan. UK and Sweden led the WHO resolution in 2014. They fought for a AMR dedicated action package at the Global Health Security Agenda, which was started in 2014. And they were really instrumental in calling for the high level meeting that we got to in 2016. They also pushed the G7 to take on this work, and they started calling for the WHO, FAO, and OIE to start working more closely together on this issue. And as many of you know, together these international organizations are called the tripartite, which is critically important since this is a One Health issue. So the major goal for international work, and it's reflected in our first National Action Plan between 2013 to 2016, was to gain political will. The AMR at that point in time was largely seen as a problem for donor nations because those were the countries that were looking for it. We were seeing it in human health, and so we started vocally calling for more attention to AMR, in particular the gram-negative bacteria. But the high-level meeting in 2016 at the UN brought the G77 to the table, and it really called attention to this global problem. In 2017, the Codex Task Force, a standard-setting body for food safety, opened up 2 work streams on AMR. The first was the Code of Practice, which the US co-chairs, and the second is on integrated surveillance. This work is ongoing. In addition, in 2017, the US was a founding member of the Global AMR R&D Hub. This was called for in the G20, and it's meant to increase communication and analysis of the R&D pipeline, push and pull incentives, and research in general into AMR from a One Health perspective. They, within the last year, they have released a dashboard of information. I encourage everyone to go take a look at it. It's early days, but it's starting to really show some interesting information. It has 3 sections to it. One is investments to AMR R&D. A second section is antibacterials and clinical development. And a third is incentives for antibacterial R&D. I'd already mentioned the tripartite, which is the WHO, FAO, OIE working together. They officially solidified that relationship on AMR with an MOU between the 3 international organizations in 2018. And in addition to that, WHO has an MOU with the UN Environmental Program, UNEP. And so sometimes you see it written as the tripartite plus or the tripartite plus UNEP. At the same time, in 2018, at the United Nations High Level Week in New York, the US, led by the CDC, started a year-long effort called the AMR Challenge. The challenge resulted in more than 350 organizations from across the globe committing to AMR. The AMR Challenge encouraged a One Health approach, recognizing that the health of people is connected to the health of animals and the environment. CDC, on behalf of the US government, encouraged commitments that focused on at least one of 5 commitment areas: tracking and data, infection prevention and control, antibiotic use, environment and sanitation, and vaccines, therapeutics, and diagnostics. And more information is available on the CDC website on that. In 2019, the IACG report was released. The IACG is the UN Interagency Coordination Group on AMR. It was called for in the 2016 declaration that came out of the UN General Assembly high-level meeting on AMR. This was a group of expert advisors from in and out of the UN system, and it wasn't explicitly government representatives. There were government representatives participating, but they were doing so in their personal capacity as an expert. The group came out with several reports, and then in April 2019, they came out with a final report to the Secretary General of the United Nations. These are excellent recommendations. They are appropriately multi-sectoral and incredibly broad. And so we're often asked, can we implement them immediately? And the answer is, unfortunately, no. Some of them are not the responsibility of member states. They would fall to the private sector, to non-government partners, to the international organizations themselves. And in the US in particular, some of the recommendations would actually fall to the states, not the federal government. We also have done some of them. Some of them remain outstanding. And like every other country, we have to prioritize the budget and support that we have for what we can do first, what we would like to do in the future, and what is the pie in the sky if we were given more funding and support. So again, these recommendations came out. They also recommended some governance structures. And the Secretary General of the UN, in his response to the recommendations, charged the tripartite with implementing these. And I think you'll hear more about this from the international organizations themselves as part of this process, but I did just want to highlight a little bit for you that there will be an independent panel on evidence for action against AMR established. We don't have a lot of information on that yet. There will also be a global leaders group, and we expect WHO to make an announcement of that during the World Antibiotic Awareness Week, the 18th through 24th of this month. We look forward to that announcement. We do understand that we are lucky enough to have one US representative on the group, but I won't get out ahead of WHO in making that announcement, but we look forward to participating. And then one of the other things that I want to call everyone's attention to is that they are also going to develop a partnership platform that will facilitate multi-stakeholder engagement to develop a shared global vision. This is meant to be a venue for information sharing. And I think as the US government, we really look forward to this because it allows for the wider partners to come to the table and be thoroughly involved, and will also allow us to come more to the table. We look forward to continuing to work with the tripartite on all three, but especially the partnership platform. In addition to this, they have set up a UN trust fund to support lower middle income countries as they develop their capacities for combating AMR. Just real quick, going back, this year, the CDC has released an updated threat report, which you heard about previously. And then recently, the US government has released a second 5-year action plan, which covers our activities from 2020 to 2025, which Amanda presented to you in the last meeting. TATFAR is a bit delayed because the same experts who work on TATFAR often work on the COVID responses in their individual countries, but the new implementation should start sometime this summer. And the US has just taken over the chair of the Global Health Security Agenda's AMR Action Package, and we will lead this effort through 2021. So in addition, the US has prioritized combating AMR in the G7 and G20, and we worked with the G77 at the UN. We are a member of the G7 and G20, but not the G77. We've also supported more than 30 countries through the GHSA AMR Action Package, and even more bilaterally on their efforts to combat AMR, including assisting countries in developing One Health National Action Plans. Health diplomacy is often about working together to find areas of common interest and consensus, and international fora are also part of agreeing to shared action. And when you look at this diagram of the countries involved, I hope you can appreciate the heavy lift in gaining agreement on international action. Every country has their own legal structure and authorities they need to work in, and equally important, they have their own domestic burden to determine. Not all countries have the capability that we do to put our own threat assessment out there. So consensus documents, global guidances, and frameworks can be critically important for countries that don't have those capabilities. But it is US policy that for countries like ourselves, if we can gather the ground truth and adapt those recommendations to our own situations, we should. And so in many of these consensus documents, we do look for that flexibility in order to take national context and priorities into account. Despite that heavy lift, we have seen the needle move in the G7 and the G20. The attention definitely started out in the G7. In 2015, under Germany's presidency, we produced a best practice brochure. It's a little out of date now, but it was certainly a welcome guide for third countries at the time. In 2016, we discussed the International Review on AMR. I think many of you are more familiar with this by it being called the O'Neill Report. This was a really interesting report because it was one of the first times we had an economic argument for AMR, and a report that really discussed the true impact if we don't take action. This is unfortunately still an area we need additional work on, with the IACG recommendations being released and many of the other recommendations coming out of the international organizations and other fora. We have a pretty good framework of action to move forward with. As I mentioned before, sometimes it's a matter of prioritizing what can be done first, second, and third, but we have and we always need more information, but we have a pretty good path forward. One of the places where we struggle is in making an economic argument for why this work should be invested in. We have a good start with the most recent CDC threat report and some of the work that the G20 has been putting together with OECD, but it's still a bit of a failed argument when we take this from the health ministers and agriculture ministers who fully believe that AMR is something that we all need to be working on, to the finance ministers and more the financial aspect of this work. In 2016, it moved from the G7 to the G20. This was a very natural move because this isn't just a problem of donor countries. And as this work progressed and as it went to the UN, more and more countries started paying attention. And this work cannot go forward unless all G20 countries are involved. The G20 agricultural ministers in 2016 did commit to phase out medically important antibiotics for growth promotion, and the health ministers congratulated them on that effort in the health declaration. In 2017, we had a global call for the G20 to do more on research and development. In 2018, they held an AMR roundtable exercise where the health ministers walked through what would happen with an uncontrolled outbreak of an emerging resistance. In 2019, we welcomed the IACG, and in 2020, right unfortunately before COVID shut down international travel back in the last week of February, first week of March, Saudi Arabia hosted a health working group on economic incentives for the R&D pipeline, discussed push and pull incentives. The conversation was resulting in countries being willing to do a self-assessment of what steps they have already taken, what steps could still be done, and looking for gaps where we could work together on this. We hope that work will continue next year under Italy, and also to note, the UK has the G7 presidency. both have highly prioritized AMR in the past. So we hope we will see it again and be working with them on those issues, and look forward to picking that up again where we left off. So as I mentioned, we recently released our next 5-year action plan. The priorities remain the same. We shorthand this to be infection prevention and stewardship, surveillance, diagnostics and treatment, and all of that but taken internationally. And if you haven't seen it yet, I do have the link on this slide. We're happy to provide that if folks want it after the fact. And we started out with an assessment of what we had done and where the major gaps were. We asked Pat Carb, the presidential, we asked Pat Carb to put together their recommendations for us on what should be covered in the next 5-year plan. And we looked at the recommendations of the international community, including the IACG recommendations, and we looked at the GAO report, which you heard about earlier today. We went back to our bilateral meetings and we looked for specific asks from our global partners. And the input was pretty consistent. Keep doing what you're doing, keep working on capacity building with other countries, keep improving surveillance and stewardship and infection prevention and control, keep up the work on research, and keep up our work on economic incentives for new antimicrobials. But there was also an overwhelming message of increase your leadership role. And we took this seriously, but we also needed to do an assessment of this, because having joined many of the fora in the very early days and using our political will to call for these actions to move forward at international organizations, at the UN, with other health ministers in our bilateral meetings, et cetera, we were a little surprised because we thought we were stepping up to the international stage. But what we realized is we needed to do more on making our international work public, and we needed to do it at a level where it will have a policy impact. And so in enhancing the US leadership in the global fight against antibiotic resistance, there's a couple things in our next plan I'd like to highlight for you. We will be looking into creating a federal champion for AMR. The details of this still need to be worked out, and in year 1 in 2021, we will put together recommendations for the secretaries of HHS, USDA, and the State Department for what this should look like, where this person should sit, what their authorities, if any, should be, and what level this person should be at. We will be looking for public comment for this effort over the year, so please watch this space. We, of course, will continue to work with our international partners. We will continue to prioritize TATFAR, which, if you're not familiar with TATFAR, it really creates a coordination at the working level for the US, the EU, Norway, and Canada to all work together so that when we come to the table at more of these global governance places, we know what the other's thinking, we understand each other's definitions and approaches better. But also it allows our technical experts to really push this work forward together so that we're better able to help third countries as well. So we'll continue to prioritize TATFAR. We'll continue to participate in the hub. And as I mentioned, we've also taken over the leadership of the Global Health Security AMR Action Package. This is one of the many fora that we work in. And just to tell you a little bit more about it, to give you an example for how some of these policy fora work, this brings together over 45 countries at this point in time and non-government partners who want to work towards improving their country's abilities to respond to the international health regulations, to increase countries' abilities to respond to public health outbreaks, to pandemics, to global health security at large. And so the strategic objectives of this have been to support the Tripartite Plus on AMR, keep AMR at the highest political levels, and create a place where guidance and best practices can be shared among Action Package members to develop their capacity to address AMR. Under our chair in this oncoming year, we'd like to refocus the action package on how countries can adequately respond to the international health regulations, and also how they can further their ability to increase their capacity building in response to the JEE evaluations. So the joint external evaluations were set in place for countries to do a self-assessment, and then a group of external experts come in and do a second assessment, and countries are rated at a score on their preparedness. Countries are then asked to come up with a plan for increasing that score and are then asked to undergo a second JEE. So one of the things we'd like to do with the action package this year is really delve into the weeds on AMR and how better to assist countries who have identified gaps in their ability to respond to AMR through the JEE, and look for tools and guidances that will better assist them in improving capacity and improving those JEE scores. In addition to that, the WHO is going to be launching a benchmarks library that will do just that. That will provide a place for people to go to for information on how to better be able to fulfill the recommendations of the international health regulations and how to improve your JEE. We'll also, of course, be prioritizing One Health work and looking for ways to bring in international organizations, financial institutions, regional organizations, etc. So I just want to end by reinforcing something that Ramanan said earlier and then making one additional point. One of the major goals for the US has long been good stewardship. And this isn't just a case of lessening inappropriate use or getting rid of inappropriate use. As Ramanan said, uncontrolled infections also cause AMR, and more people are dying from lack of access to these drugs than from the antibiotic resistant infections themselves. So the goal is really getting the right drug for the infection at the right dose, the right duration every time. And this is a heavy lift in the US, but it's even heavier lift globally. And the second point I'd like to leave you with is that the economics of action is incredibly important in making this argument with our global partners for more to be done. As I said, we have excellent recommendations on what the next steps should be. We have guidance from the international organizations helping countries decide what to do next. We're still lacking some of those solid arguments for why this will save you lives, save you money, and help your health infrastructure in the long run. So I'll leave it there and am available for any questions. Thank you.
Thank you. Thank you, Lynn. We do have time. Let's see, we have time for maybe one or two questions before we ask all the speakers who are available to come back for some more open questions, more open discussion. So let's see, I don't have any questions in the chat, at least not to me. So are there any questions for Lynn? And you know, it's fine for people if you want to start maybe turning on your video, otherwise it's just going to be difficult to know. Okay.
I'd be happy to ask one.
Okay.
Not a bit outside of my domain, but I'm curious. You mentioned economics a number of times, and how does one go about not undermining livestock-based economic development, let's say in low and middle income countries, and yet trying at the same time to restrict antimicrobials in animals? It sounds like there's not one size fits all, but at the policy level, how tailored are some of our international efforts need to be or are in the context of economics and low and middle income countries on that very issue? Thank you.
Yeah, it's a good question, and it is a very complicated issue. It was frankly a lot easier to come to consensus on paths forward before 2016, when we didn't have the entire global community, coming to the table with real information and ground truth. And also there continues to be a need for increased animal protein and safe food as well. And so in looking for ways to improve the use of antibiotics globally with good stewardship on the human health side and the animal health side, we do need to make sure that we are not tying people's hands in treating real infections in livestock as well. So one of the things I had mentioned is the global AMR R&D hub is starting to present data as part of the dashboard that they have been putting out there. And one of the really obvious things from that dashboard so far for me is that the investment that we are putting into the human health side is not there on the animal health side. And by we, I mean globally. The global community is not putting enough effort, in my opinion, into making sure that best husbandry practices can be implemented, and that people in the US, as well as our global partners, have the tools they need to not take an economic hit as they phase out medically important antibiotics when they're not needed. And again, when we need them, the same antibiotics are critically important for animal health as are for human health much of the time. So we're not doing a good job of investing in alternatives. We're not doing a good enough job, in my opinion, of investing in vaccines for prevention. And the more data we collect in this area, the more obvious that is. It's incredibly difficult to ask domestic livestock folks, as well as our, not to mention our global partners, that they have to ban antibiotics and take an economic loss when we're not giving them the infrastructure and the tools they need to do it safely and to maintain animal welfare and safe food. I think the conversation and the difficulties we have would go a lot farther if we had more support in that area.
Are there other questions for Lynn, or if not, then we will start. Oh, I think I am getting. Any other questions for Lynn? I don't know if Michelle or Lefteris had hand up, or do we want to start on general questions?
I have a general question. Thank you.
Okay, let's do that. Go ahead, Lefteris, and then we'll start. We'll move on.
It was a very.
Sorry, can I ask people to turn their cameras back on, please? I think it would help.
I would like to thank all the presenters. Those were very concise, very informative presentations, and thank you. What do you think can be done in order to facilitate interagency communication and collaboration? Are there any blocks that you see when you try to, for example, combine wastewater data with FDA usage data? Is there any stumbling blocks that you see that we can ask people to break those walls for you and work better and more easily between the agencies? Thank you very much.
Jillian, this is Tim. I'm still on. I can start to answer the question. I just can't turn my video on. I don't know how
No,
I do that.
that's great. That sounds great, especially given your perspective.
Yeah, no, thank you. So it's an excellent question. As I mentioned earlier, again, easier said than done, but I think, not to sound trite, but I think the one thing that's needed is sort of that centralized pan-governmental White House kind of leadership put in place to cut across these things. This is more than an advisory body across the coordination groups, and then you sharing information. That is important and necessary, but you really do need someone who is empowered. That's I think where it gets frictional, to try and again lead this, or using an American football term, quarterback this kind of activity, whether it's directing R&D or setting the boundaries or a range of that, whether it's encouraging any sort of research in the regulation sector to make something happen. It would be outreaching to the private sector, because we need to have to deal with those, having the conversation about how to deal with those market failures and so on. So I really do think you need a White House level, almost like a National Security Council like person to be able to deal with that. Thank you.
If I could add to that as well. So we did have that back when CARB was first established. We had leadership out of both the NSC and the OSTP. And it was incredibly useful to bring the entire interagency together to work on this issue. It will certainly show up when they call, but that person didn't mandate to the agencies. That group of people actually didn't mandate to the agencies. The agencies still have their own authorities and abilities to do certain types of work. And so I do think it helps to have someone or a group of someone's at the highest level of government to really understand how all the different agencies work and how they can work together. But it's still not as simple as that group or that person could then tell CDC to do work outside of their mandate, or tell USDA to do work outside of their mandate. They were very forward thinking when we did have that. They set up the tri-lead, of course, which you heard about before, of the DOD, HHS, and USDA to lead together the task force. And that established tri-lead still exists. On the international side, it was my office, Office of Global Affairs, USDA, and the State Department, to also make sure that when we're developing policy for the US government, everyone is involved and we are reaching across the interagency. And that was institutionalized before the last transition. We'll have to see, of course, when we go through another transition, things do change. But we did have that when we started out.
So if there aren't other feedback from Jay or the other speakers, I'm going to move on to a question. This is from Marta Gomez-Chiari. And it's concerned with the argument about strengthening water monitoring and using it as a surveillance and a risk management tool. She asks, what are the challenges and opportunities that you see in monitoring in local and state efforts for water quality surveillance? I can go through that again. I know there was a lot there. So.
I mean, I think, one of the reasons why Escherichia coli and E. coli as a target, and even Enterococcus to a certain extent, have been identified as targets for water monitoring, is that there's a lot of existing infrastructure and reporting that is done based on those targets. Maybe not for resistant forms, but there's a lot of fecal indicator monitoring out there. So that's why it's identified as one of the best approaches to leverage existing kind of knowledge and programs. So, I mean, I think that is one thing, the leverage. Getting back to the first question a little bit on this topic, I mean, my experience to date has been that there's been really very, I guess, encouraging interaction amongst the agencies as we develop these plans to do the surface water work. I guess this is at a much more focused level than maybe Lynn was talking about, at a higher level. And I'm not denying that you don't need strong leadership, but I think, like I said, I'm encouraged by the dialogue at the scientist level, and really, and we'll see how. Check with me in 6 months or so and see how this fully develops. But the date has been very open and useful. And I would note one other thing on that too, is that one of the silver linings of the COVID pandemic, the question was about wastewater and how you relate it to some of the other measures. You know, the COVID crisis, I can't, you know, EPA and CDC, we work together, you know, on a weekly basis. You know, we have at a staff level on this issue. So it's really been a way to bridge some of the maybe the differences between public health agency and maybe the environmental agencies, because it's seen as a real continuum. To address the COVID and looking at monitoring and wastewater, it involves close connection between the utilities, kind of environmental analytics, and public health. And those three components are what you need to develop an effective monitoring program for AMR as well. So that's you know, crisis, I think, has pushed some of the integration there, and I think it's something we could build on.
Could I just ask, as a follow-on to that comment, is there international collaboration? Are there international networks looking at wastewater and particularly trying to standardize approaches, measurements, indicators? What is happening in that sphere?
On AMR in general, or on COVID?
Well, on AMR and on genes and residues, yes.
Yeah. You know, I may not be the best one positioned to talk about that. I know Pat McDermott, who's been involved in TATFAR, and that's something that I've been invited into in the coming weeks, and hopefully that's something that can leverage some of the cooperation amongst different nations when it comes to the environmental. The WHO Tricycle project, like I mentioned, is one that is being used as kind of as an example, at least trying to standardize ESBL E. coli as a target. And beyond that, I'm not sure, I'm not aware of any other specific international efforts. But like I said, I've just recently been kind of introduced into the TATFAR conversation.
Yeah, unfortunately not formally yet, but it is a very current topic of conversation in several different fora. So TATFAR has certainly already brought it up, and the Global Health Security Agenda AMR Action Package has already brought it up. We just co-hosted a side meeting. The GHSA ministerial is going on right now. We had a side meeting on AMR in the time of COVID, and it is something that is acknowledged to be a problem, and it is something that someone said it earlier, that they hoped the wastewater work on COVID could be used later on, and that is something that is already being discussed, but there isn't a clear path forward yet on the best group to sort of have that mandate and take that on domestically or internationally.
So are there any other questions for our presenters? Well, if I'm not hearing, so if you have questions, please just jump in, or you can message them in the chat. Otherwise, I would like to thank very much the presenters who joined us today. We're very grateful for your time, and this has been really informative. We'll continue to be in touch. I have referred you all to the study website, where we'll continue to post information about the project. And please feel free to join again tomorrow and Wednesday, and to share this with your friends. I'm sorry, I'm afraid that I might have had a question. If I missed a question in the chat, I'm very sorry. Anybody who needs to give one, please jump in. But just in short, thanks to all our presenters, and I hope you'll be back in touch, either watching the meetings over the next few days or again in January and over the course of the study. Please don't hesitate to send any emails. So Guy can't be here right now to adjourn us, but sorry, Tim, did you have closing comments that You were
Yeah,
good.
no, I was just synthesizing. I was saying, you know, great points from my co-presenters on the thing. I just wanted to clarify that ultimately it is true. It's not that like a centralized NSC level person is supposed to quote unquote tell agencies what to do or expand their bounds beyond what statute allows. That's all true. Someone needs to understand those various agency components, and again, that quarterback analogy, right? You have players of the field, they're going to play in some concerted way, and understanding how they need to do that, who does what, and so on, does need that centralized look. Otherwise, it's just muddling through, and I don't think muddling through is an acceptable kind of posture on this problem if we believe it's of the magnitude that we think it is. Thank you.
All right, then we have a few minutes early today, and you know, looking forward to seeing everyone again tomorrow. Thank you all for your time, and good afternoon, or good morning, or good night, as Guy always says. Take care, everyone.
Thank you.
Bye-bye.
Thank you.
Thank you. Bye.